Hey, everybody, and welcome back to the Migraine Mentors mini-casts. We are your migraine mentors. My name is Dr. Eric Reese, and I'm here with Dr. Thompson Mayasaka. And today's topic is something that has been on our minds for a little bit. We continue to get emails and questions and feedback from patients in the clinic, but then also via the newsletter about migraine versus headache. And I know that this is something that is heavily debated. A lot of people have questions about it. So we wanted to just touch off and start off with just this question of what is the difference between a migraine and a chronic tension headache or just a really bad headache? Thompson, I feel like you're somebody who's very well equipped to answer this. So can you just share with everybody kind of how to understand the structural framework for thinking about this?
Yeah. Yeah, it's a great topic and one that's super misunderstood. There's a couple ways to look at it. The first is just from a mechanism standpoint. Think of migraine pain as an explosion that happens in your brain that knocks out certain parts that have specific functions, specifically the ones that block out pain. So you have this brain explosion, and the areas that are supposed to stop pain from sort of reaching your experience don't work. So all the pain gets through, and you feel a level of pain that's just so much greater than any normal headache could possibly be. Just a different type of pain. Headaches are usually you can localize them to sort of a singular thing, which is different than migraine. So if I have a cervicogenic headache, it's coming from my neck. If I have an inflammatory headache, it's coming from some source of inflammation, right? It's usually one or two pretty simple causes that are pretty linear. It's like, okay, well, my neck hurts, so it makes sense that I have a cervicogenic headache. So when you just look at it like that, it's just mechanistically super different. And then when you really break it into, I think really the source of the problem is the diagnostic criteria for migraine is super vague.
Mm-hmm.
So, Eric, I want you to put yourself back at college. We both went to the same school, University of Minnesota. And I want you to tell me if these criteria fit any type of headache you had back on maybe, say, a Saturday morning. So, headache that lasts 4 to 72 hours. This is a diagnostic criteria for migraine. Lasts 4 to 72 hours, and you have to have two of the following four characteristics. It hurts on one side, it pulses, it hurts moderate or severe intensity, and it's aggravated by physical activity. And then you add in another criteria, so you have to have at least one of these: nausea, vomiting, or light and sound sensitivity. So I can think of at least three headaches right off the top of my head that sound like that. A hangover is one of them.
Exactly.
And
It,
it's so vague. Like for such a complex condition, the criteria for diagnosing it is so vague. That's why everyone just gets thrown migraine medications. It's like, oh, okay, that sounds like a migraine. Just take these.
I think the bigger problem with it too is that what we've seen is that people get put into one camp or the other, and they're like, "Oh, well, I was told this, but maybe it's actually this, or vice versa." And the one thing you mentioned this before we even went live is, people are allowed to have more than one thing going on at a time, right? So, do I have patients in my office right now as we speak that have cervicogenic headaches throughout the day? Yes. But do they also have migraines that surround their menstrual cycle when they have a massive drop in estrogen? They get this massive influx of pain, unilateral kind of pain over the eye, over the face, and they have an actual migraine? Yeah. So it's not like straight cut, it's not cookie cut, and every single person is different. But this is the hardest part for so many people about headaches and migraine in general is like, what do I have? Well, how does that change your treatment? And what does it look like? And we continue to come back to this over and over again. That's why you have to look at somebody structurally, neurologically, and nutritionally. And it's never, ever been because we want to, because it's so much easier to not have to do that. It's because we genuinely have to in order to help 90% of the people coming into our office who've seen 10, 15 other doctors before us. So I don't know. Would you add anything else to that, Thompson?
Yeah, I mean, I think the concept of being open to having more than one type of headache is really important because typically with primary care, they're not. I don't want to bash anyone, but typically, just from clinical experience, they aren't very well versed in breaking down. Okay, this symptom is coming from your tension headache, and these symptoms are coming from your migraine, and the cervicogenic headache is the thing that's underlying all of it. It's kind of just lump all the symptoms into one diagnosis and just say, try these pills. And it's still to this day just so shocking to me that even some people that have migraine, that have been diagnosed with migraine, don't even really have it. Um,
Mm-hmm.
most people, I think this pervasive belief of, okay, we all get headaches. And if my headache gets really bad, I'll get nauseous and light sensitive. And that means it's crossed into migraine land. I believe that for most of my life, honestly, is the discovery that I was just super wrong is what made me just go all in on migraine.
Yeah.
But I think people still in our office believe that. And they've just, it's not their fault. So it's just shocking to me how many people are walking around saying they get migraines when really they just get wicked tension headaches or cervicogenic headaches. You were talking about someone that you just had.
Yeah, I have somebody in the office right now. She was diagnosed with vestibular migraine. And so, after working for her for the last couple of weeks, she has dizziness, okay? But it's not just periodic. It's relatively frequent, we'll say, specifically in busy visual environments. She is somebody who previously was involved in a pretty heavy auto accident. Now, you can have migraine after an auto accident, you can get tension headaches, you can get both. But her presentation for her headaches is just so different. It's both sides, usually over her forehead, over her eyes, and over her temples. I can recreate it specifically with palpation and trigger points over the base of the skull, over these suboccipitals. Um, Her symptoms don't really change around her menstrual cycle. Okay, so asterisk on that. Not everybody has to have a migraine around their menstrual cycle. But her presentation is just so different. And after we've been doing therapy and structural work and some visual rehabilitation, she's doing better. She's got more bandwidth and she's just more functional. And it's like, well, I didn't really treat her as a migraine patient originally because I was trying to investigating. I just always treat the person in front of me the way they need to be treated. But now with her, I'm like questioning, and I've been talking to her. I'm like, like, do you think these are actually vestibular migraine based off of what I've talked to you about and what you've heard? She's like, no, I've questioned that. And so it's okay to question that though, right? Like, it's not like you have to have it or you don't. Like, that's not your identity, right? No diagnosis will ever be your identity. But it is important because now we're looking at other things in a very different manner. And so that happens more often than not. It's not like we're the only ones that ever find this, right? But it's frustrating to know that some patients feel like they need to go all in on one or the other, and you're allowed to have a couple things going on, and then more importantly too, what does the resolution look like, right? Like treatment for a migraine could look like a cervicogenic headache sometimes, not all the time, but there are overlaps with that. So I don't know, Thompson, is there anything that you would add for somebody who feels like they've maybe been mislabeled or misdiagnosed on that side of the house?
Yeah, one of the unfortunate things that it could be a fortunate thing, depending on how you look at it, is the people that I've seen, at least, that have really complex conditions that do the best are the ones that relentlessly they sort of just take matters into their own hands. They
Yeah.
self-educate, they abdicate really strong for themselves. And I think that's kind of what you have to do if you want any sort of credibility, not credibility, just traction in the medical field. If you have headaches, just, and again, I'm not knocking the medical establishment at all. They just have a very specific skill set designed to prolong life if something very dangerous is happening right now. If something not as dangerous but still problematic is happening over a long period of time, that's just not their skill set, and they're not trained to manage those things. So first of all, we just need to get that expectation calibrated appropriately, because I think that's a huge reason why people are leaving so disappointed. And also, because of those shortcomings, you need to come ready with information, maybe some research, a coherent argument as to why you think these things are happening the way they're happening. And sometimes you're just going to strike out with that particular provider, and that's just kind of part of it. It's
Yeah.
such a sad reality to admit, because it seems I get lit up on TikTok every time I post about this, because it's like you get those naysayers in the comments that are like, "That's not our job. That's the doctor's job," or like, "That's literally what they get paid to do." And it's like, well, they're not wrong.
No, they're not. They're not wrong. And I think that that's the hardest part is patients have never taken a course or a class on how to be a good patient, right? And so there is an inherent expectation on doctors, and rightfully so, that they should be the ones calling the shots, managing your care, helping you along the way, and being your healthcare co-pilot. And if you're looking for that in the standard Western medical model, you unfortunately won't get it because you're at max going to get 10, 15 minutes with your primary care doctor. And then you're out because you're another number for them. You're going to be put in and put out. They'll finish your note up and then they'll say good luck. And then it's your responsibility to remember to book follow up, to hopefully have the follow up care. remember what they said, keep them honest on things, because doctors inherently forget things too. They're human, right? But I think that's I think that's what I enjoy about our model is like I get to spend an entire hour with the patient. The follow up is so much easier and streamlined. They're always communicating with me, and I'm not saying that that's the best option, but I can at least control their destiny and at least empower them and help them to do that. Now, if somebody out there in some way, shape, or form was like, listen, I want to create my own GPT AI based program, and I want to create, a Google Maps for someone's healthcare journey and autopilot all of this healthcare decision making, go for it, right? Like that's a brilliant company to build because every patient on the planet would use that. I would, because it'll automate everything you need and be able to give you structure for your function. But until that happens, you're unfortunately stuck with the advocacy that Thompson mentioned, which sucks, but it's the reality of it. And the patients that I've seen are the ones that do own that and they take control of it and they are bullish on being able to make those shots. So if you're waiting for a follow up or a phone call from your doc and it's been days, weeks, months, or sometimes years, probably a chance it's not going to happen. You got to take controls in your own hands. So,
Yeah.
what else would you add for the discussion about migraine versus headache? Any specific criteria that kind of clinically for you, you're like, I'm leaning more one way versus the other, with regards to somebody coming in with maybe a neutral diagnosis of head pain?
Yeah, one of the things that tips me off that is the first question I'll ask is when did you start having these? So, real migraine, with the exception of I got in a wicked car accident and I used to get maybe one migraine a year and now I get 15. That's
Yep.
different. If you've never had a migraine in your life and you say, yeah, I got in this car accident and all of a sudden I get migraine now, those aren't migraines typically. True migraine will start right around the time you hit puberty and just progressively get more problematic as you get older. It tends to peak in between 30 and 55. So that's always kind of how I start is if
Yeah.
that hasn't been the trajectory so far, I question whether or not there was either a misdiagnosis or some other form of trauma or insult that suddenly brought very infrequent migraines up to extremely frequent.
Yep.
They're both allowed to happen, but that's a really good way to triage if it's actually true genetic migraine versus just a
Yeah.
misdiagnosis. How do you tease that out?
Same. And then family history for sure, right? I'll ask about family history. I'll ask, do your brothers, sisters, family members get migraine as well, similar headaches? Um, there was one of the TikToks that kind of went viral for me recently was the kind of correlation in the, we'll say, similarities between migraine and seizure. So there's a lot of similar genetics there. There's a lot of similar presentation. There's a lot of similar neurophysiology there as well too. Um, Kind of talking about like when a migraine comes through and sweeps, you get that cortical spreading depression and what happens to the brain. A lot of brainstem mechanisms there, and so yeah, I'll ask about some of those things and pick them apart. But then I think for me clinically, I'll just start trying things. And so if I notice things that correlate more with like tension headaches or structural based headaches, I'm like, okay, I have more conviction. If it's more migraine, more episodic, more around the cycle, or more hormonal induced, then I'll chase that rabbit. So I'm always looking for relief, and I know you are too. So um, Thompson, anything that you would leave people with as far as a parting word for kind of ending this episode?
Yeah, I would encourage you to, again, for a third time, I'm not trying to crap on anyone here. It's just the way it is. This is just the truth. Um, Calibrate your expectations of what the medical system is actually going to do for your headaches. If you get lucky, you'll have a caring, empathetic, well-rounded headache specialist that gives you medication and also suggests a bunch of alternative things so you don't rely as much on that. That's extremely hard to find. It's more likely that you get the medication and obviously make sure nothing is like going to kill you from your headaches, and then seek out someone like Dr. Reese or I that's very well versed in sort of quarterbacking headache care and management. Um, I think having those expectations set appropriately can help you not leave the office super disappointed and
Mm-hmm.
defeated, because that's just part of this journey. Is it's hard,
Mm-hmm.
and you can go. I met a person a couple months ago that they'd seen 9 primary care doctors, and every single one of them was the same. It was like, I don't know what it is. Here, take these pills and just please get out. So if you manage those expectations and just understand that the full 360 management of nuanced headaches is not really in their skill set, it gives you the freedom to look for someone that actually has worked to develop that skill set, like Dr. Reese or myself. And it's a big world. There's a lot of different types of headaches, and sometimes it just takes someone that's seen a lot of them to help you pick apart which parts are feeding into your whole presentation.
Yeah, that's great. Yeah, I think that's a phenomenal way to end this. So, for those of you who are listening, thanks for tuning in and joining us. For those of you who aren't subscribed to the newsletter, we are the Migraine Mentors newsletter. We list our newsletter every Wednesday morning at 6 a.m. Central Time. And so we are here to not only help you naturally and holistically treat your migraine at home, but more importantly, to take less medication, hopefully find more relief. So for those of you who are joining us, go subscribe in the link below. So you can subscribe to the newsletter. And until next time, we will plan on seeing you then. So thanks for joining us.